I think the PI3K pathway is quite evident in multiple tumor types, and so I think it's not necessarily just restricted to breast cancer. It clearly links with endocrine resistance, and I think HER2 targeted therapy resistance as well. But it's a key signaling pathway that has multiple different drivers and different mutations. So is it amplification, is it mutation, and should they be addressed the same? Do they work the same? So I think in the Fergie trial, I think what we saw is, clearly there's a signal of efficacy. I think it may have been hampered somewhat by looking at the archival tissue that was in the primary. So, not reflecting necessarily already an exposure of endocrine therapy and now metastatic status. So I think, we're trying to learn, and my own practice as well as that of many of the colleagues are getting into now this new practice of rebiopsying tumors at every progression, because obviously the progression is a signal that there's a new resistance pathway. And I think, that might have provided a little bit more clarity just because it was the primary tumors. On the other hand, not all disease in the metastatic setting is easily accessible to biopsies, and so it hampers accrual, because you have to have tissue that's accessible, for ER positives, it's difficult because it's a bone-only disease, and so biopsying bones, unfortunately, doesn't lend itself as well to some of these DNA investigations. And so I think, what's exciting that I've seen here is, different ways of now trying to get tumor DNA, circulating tumor cells. Can we get, these tissues, access to tumors in different means, or that data from the DNA?